Forward Media. This is Healthcare Musings. I'm your host, Dr. Hashem Hasabala. Welcome to Healthcare Musings, everybody. Happy to have you with me. I'm very honored and delighted to have Dr. Scott Matson. He is Associate Professor of Medicine at the University of Kansas. He's a pulmonary critical care doc like I am. He is a clinician-scientist, and I really, you should all subscribe to his Substack. It's great. It gives you a great perspective on being a clinician-scientist and the sacrifices that they make to advance science in our field. And so I wanted to kind of have him on to give us that perspective and to kind of give him the perspective of, okay, what am I supposed to do with the things that come out of the academy when I'm in the community where most of the care is being delivered anyway? So welcome, Dr. Matson. So happy to have you.
Well, thanks so much. It's really great to be here. Appreciate the opportunity.
Absolutely. So I read your last article about being fundable and how difficult those, getting the, and it's kind of lingo that I'm not necessarily familiar, like K awarded and R. And I know the R grants are the big grants from the NIH, and that's what people stake their entire careers on. And what I appreciated the most about it is to how much you sacrifice by being a clinician scientist. Just tell us more about that.
Yeah, well, I appreciate the opportunity. The piece that you're referencing that's on my Substack sort of describes a phenomenon that I've witnessed as someone sort of going through academic fellowship and then transitioning to an academic faculty position in soft money environments. And what that means for a clinician scientist is that, we do a portion of our time and salary that comes from our clinical revenue. And then a portion of our salary comes from grant funding efforts where you apply for a grant through a federal funding organization like the NIH. That comes with money to do the research, but it also comes with money to pay for your time that sort of allows you some space aside from your clinical time to think about, advance, work on your research. And, one of the incentives and the pulls that I feel for people who do clinical science is how do you find the kind of projects that actually get funded? And how do you think about building and bringing in more people to the academy who can ask meaningful questions? And, really, I think, hopefully for all of us, push the science forward for what it's like to care for people in the ICU or in pulmonary clinic. And one of the things that I see, which I think is a tension that we could probably talk about, is that and I think sort of referenced in your intro, is that a lot of the science that's being published, even by clinician scientists, if we're honest with each other, is stuff that doesn't really reflect what it's like to practice medicine day to day. And a lot of the research that's being funded are projects that are so far removed from what it's actually like to care for people. Now, in some domains, we of course, we hope that there's sort of a blue sky science where we might learn something that we never knew before, and that might, downstream really change the way, we practice and think about and give medicine to people. But one of the things that I feel, and I was sort of commenting on in that piece, is I think that some of this comes from this sort of phenomenon of what it's like to try to build this career from scratch as a clinician scientist, and this tension that people feel of, I want to do this thing or study this disease or study this part of medicine that's important to me versus I want to do the thing that is more likely to get funded. And sort of what's the primary goal here? Is the primary goal here just to get the grant to sort of keep the finances rolling in a soft money environment? Or is the goal here to do something that you think is actually meaningful that's driven from your clinical career? And that's a tension I feel as a clinician scientist trying to get grants. And so the piece sort of comments on that if it's something that I feel, I imagine it's something that other people feel. And I think it's a reasonable tension. I think it's easier to get more grants once you have the grants, and it's easier to keep doing the same kind of thing that you've done once you have the grant. And that kind of iterative science of more people doing the same kind of thing or the same labs doing the same kind of thing, getting more and more of the funding, I think it's just an important concept to think about as we all sort of think about what it's like to build a career. So that was sort of the I don't know if that's that clear, but that was sort of the impetus behind the piece.
No, I mean, that makes a lot of sense. And you hit the nail on the head. Like, Okay, so I know you had a conversation with Adam Cifu here in Chicago, great guy. Had him on the podcast as well, about talking about evidence-based medicine and as a clinician leader, as a physician leader, and all my programs that I run, we want to do evidence. I mean, I talk about it. We want to run the most evidence-based medicine as possible. I want everyone in the ICU that comes into an ICU which I oversee, they should get the same evidence-based care, whatever that is. Just if it's diabetic ketoacidosis or pneumonia or sepsis or whatever. The issue is the evidence that keeps coming out. A lot of it's just like you said. It's removed from what am I going to do with this? I just read I don't know if you know the poem CCM uh, Substack. It's really good.
Yeah.
He's also a pulmonary critical care doc, and
Yeah.
the last one he talked about was this biomarker study about kidney injury, and then there's no difference in dialysis. Okay, so who cares? I just don't understand how that's gonna. And then I'm not trying to disparage the need. We have to take care of our patients with the latest. If the evidence says you should do it, you should do it. And if the evidence is just esoteric and meaningless, then it's what are we doing here?
Yeah. No, totally. That's a really great point. And it's certainly something that I see and feel, uh, in the kind of work that people do and publish nowadays is, if you remove yourself from the top tier, high impact medical journals, if you move from one tier below New England Journal and Lancet and JAMA and go to, that next tier, which is where I think a lot of like the clinical science lives. This is like top tier foundation journals. Like in our field, it would be like the ATS journal, like the blue journal,
Right.
we call it, the
Yes, the
AGRCCM.
Blue Journal, which which has things that just mean nothing to me. I mean, 90% of that journal, which is why I don't read it. It's just
Yeah.
meaningless to me.
Right. And like, like I've published there in things that it's like, who's reading this and to what end is it mattering? I mean, uh, you know, I, nominally what our group does is we study interstitial lung disease, and we're interested in how we can improve treatments. And so, we're trying to do clinical trial design, and we're trying to get federally funded grants to do that kind of work. But at the same time, we're interested in maybe how we can use, large scale omic technology to maybe understand how diagnostics should work. And maybe there's people that could respond to treatments regardless of what we call them. But like with that kind of work, it's, you might publish biomarker studies, which is like, we look at the proteomics, we find these biomarkers, they might predict something about prognosis, survival for these populations. You get a grant to do that kind of work. It's $1 million. You look through large data, you get a big repository of patients, you do all that work and then publish a paper, and then sort of there it lives. And it's like that next step of like, so what does that mean? What are we supposed to glean from that? What are we supposed to know from that? And honestly, like, that's at the highest impact sort of journal for this kind of stuff, because even beneath that, there are probably 50 pulmonary journals beneath that are publishing even smaller sample sizes, even less clinically relevant questions. And again, it's not that people are like bad or not understanding the problem. It's just, for me, it's all about incentives. It's all about like, and then that goes back to that fundable question is, it is so much easier to write a grant and then write a paper that is nominally looking at biomarkers of survival, even though that's what people have been doing in this space for 30 years. And it just has not made any major clinical forward progress. And in my space, in interstitial lung disease, we have this bleomycin model, a mouse model, where you give a mice something like a lung injury, and then you interrupt the genes of that to sort of look at your particular target. And like, we have cured pulmonary fibrosis in the bleomycin mouse for like 40 years, and yet we have no transformational meaningful therapies. And so if you're someone who wants to be a clinician scientist and study ILD, for 3 decades, the story has been the way to do it is to get yourself, big biomarker projects, find these pathways of interest and then explore it in a mouse model. And then, there, you've got a funded program that's getting $1 million a year to do that work. You're publishing papers in high impact journals. And yet, like, if you keep doing that same thing that we've been doing for 30 years, like, are you really hoping to make a difference? Or is the thing you're hoping to do just keep the program going? Because those are all the top-down incentives, like your division chief, your department chair, the people that you work with and work for you, all of them really just sort of want that program to keep moving forward. And of course, what I'm trying to sort of say is like, maybe we should be a little more disruptive about how we're thinking about that kind of funding, how we're thinking about how we do that kind of work.
Yeah, that makes a lot of sense. I think both can exist in the universe, right? Again, most of the physicians are in the community like me, right? Most of the care in the country is being taken care of in the community, and we want to do what's best. And we look to you in the academy to show us. And I think so. I don't know that it's a zero-sum game, right? The problem I have sometimes is that like you said, the research is that's coming out, it's not clinically meaningful. And I'm a reviewer for critical care medicine, and I come at it from a community physician who's looking at this paper and how is this going to help me take care of whatever the disease, whether it be sepsis, and we'll talk about that, whether it be interstitial lung disease, whether it be shock, whether it be renal injury. How is this going to help me care for my next patient that's going to come in the ICU? And a lot of times, I don't know how this paper is going to meaningfully impact my clinical care of the patients that are coming through my ICU door. So I don't know that it's a zero-sum game. And what was frightening is that when you read others in our field, in the medical field, they could say, you can just change the statistical test and have a completely different outcome, which is which is frightening. Then everything, all the assumptions that I had before can be false if you just change the way you look at the data or how you parse the data. What are your thoughts about that?
Yeah, it's a really great point. Well, if you think about incentives, one of the things I always think about is, you know, really the way that we, of course, understand treatments and therapies in any facet of medicine, but certainly for critical care and pulmonary medicine, is via a randomized, clinical trial. And um, outside of the ICU, unfortunately, um, about 95% of all clinical trials that are being run and funded by the industry. And what we hope for as a field, as clinicians seeing patients, what we hope is that there's that Venn diagram between sort of industry, which is doing trials often for regulatory approval. So if you have a new drug, a new molecule, and you think it might help in sepsis or it might help in interstitial lung disease, you have to do all the preclinical data and then take that through phase 1 and dose finding studies in phase 2, and then eventually a large phase 3 study to show it matters compared to something like a placebo or standard of care. That's a hundreds of $1 million process most of the time. And, the academy doesn't really have the kind of resources to do that. There are ways theoretically to do that, but that's a huge program to try to build financially within the academy. So we need industry to do that. And what we hope is that there's a huge confluence of interest. We hope that industry is making better drugs because that means more money for them, and it means better drugs for us to use for patients that actually meaningfully improve care. The thing is that for industry, if they are in charge of designing their own trials to prove clinical efficacy, there are decisions they can make not only in the statistical analysis, but there are decisions they can make in the clinical trial design such that, of course, a company that is primarily, trying to look out for shareholder value. I mean, there again, like this is not malintent. This is just intent. This is just incentive. Any company who's designing their own clinical trial, who's already invested $100 million into this molecule, if they're given an option to make a decision for that clinical trial that favors their drug versus not, of course they're going to make that decision. And they might make 10 or 20 or 30 or 40 of small decisions that likely just move that P from, 0.00 0.06 to 0.005, because on that side of 0.005 is $1 billion, and on this side is a company that folds, right? And so that kind of incentive is enormous. And for industry, like, they have that job, they have that role. For us, it's important for them to do it. But if we don't ever, as the academy and as clinical practitioners, find a way to sort of push a little bit against that side of things, what we're going to often have is more and more drugs being approved by regulatory agencies that are moderate to marginal value to patients and maybe of no value at all. I mean, if a drug only improves surrogate outcomes, like in our space, if a drug can only improve forced vital capacity, lung volume changes over time, but does not impact survival or quality of life, I mean, that's a very marginal benefit for a drug. If you can't make people live longer and you can't make people live better, the question is, what are we actually doing with that medicine? If a patient is unaware of their own FVC, it's really hard to say that that's a meaningful drug. And yet, there's no space for us as the academy or as clinicians to take that next step and sort of study that drug in other meaningful ways. It just makes that space pretty difficult. It makes it hard to sort of know how to interpret that evidence as people who just are sort of like you and I. You get the article to review, or you get the article to read when the paper comes to your house, and you say, like, well, this isn't really that meaningful for patients. But that's largely because the incentives are aligned such that that company is really looking for financial gains, which they're a company, they should. And what I sort of believe is that the role of the academy, and if clinician-scientists, instead of necessarily focusing on just fundable projects that probably aren't going to move the needle, if our role was more like, let's take these drugs that have efficacy against placebo and let's do studies in real humans and patients and design trials that are actually clinically meaningful. Like, let's compare these treatments head to head against standards of care. Or in the ICU, like, if we have, like, a lot of the pragmatic clinical trials groups in the ICU do a fantastic job of this. And they say, we have a couple of different ways to intubate people. We don't know what's best. And so they design a study to do that. Right. And like, more of that kind of thing within the academy, I think, is the kind of thing that to me would be a refreshing take on what's our role here. Is it to pump out more and more publications weekly in journals that people aren't really reading and don't really move the care? Or is there something else we could be doing that would really matter to patients, to our colleagues, to ourselves when we're in the unit? Are there things that we could do with that time and energy and resources?
Yeah, those are fantastic points. And you brought up the thing that I really wanted to talk about. Was one of the things is mortality. Everything is focused on mortality, and I get it. If you have a drug or a treatment that kills more people than it saves, that doesn't make any sense to do it. If you have a disease such as interstitial lung disease, for example, let's bring that example. I see these people. It's a devastating disease, very debilitating, very disabling. And if there's a treatment that, in my mind, okay, they don't live longer, but they live better. They are less dyspneic. They're not suffocating as much. They can do more. They have more function. They have more function. They have better quality of life. Even though they live they're the same as placebo, but the people in the treatment arm have a better life. What's wrong with that? Why is that a failure if it doesn't improve mortality? If it kills people more, no, that's if it's toxic and it kills people, that I get it. But if I have a patient in my office that I see who's now breathing better, can do more, can go out with their kids or their grandkids or their family, and they need less oxygen, or why is that a quote unquote negative study? If they have a better quality of life, isn't that the point? We keep trying to beat death, and it's not gonna. I'm just telling you, it's not gonna happen, right? We're not gonna beat death, and we have hubris to think we're gonna be masters of the universe and to conquer death. We're not gonna do it. If we can help our patients live better lives, what's wrong with that?
Yeah, I'm with you. And if you ask patients, if you ask them, like, what would you want if you take 100 people with ILD and ask them, if we have a new drug, what's most important? If depending on how you pose this question, people want what you say, which is they want to be able to go to their grandson's graduation and not lug around oxygen and be able to walk up the stairs to sit next to their family. And they want to be able to participate in their life in a meaningful way. And because of the nature of a progressively fibrotic disease, I'm with you. I think it's very unlikely that we're going to have a transformational drug that's going to return that lung back to normal such that life is going to be meaningfully returned to what their pre-diagnosis lifespan was going to be. I suppose it's possible, but I agree it's very unlikely. And so I guess it comes down to what are the endpoints we should select that actually matter. And my belief is it should be something that the patient wants. And they do want to live longer. If that's not an option, or if it's minimally impacted, or even if it's negatively impacted slightly, but comes with a major trade-off for how good people feel, I think many patients, when given that question, would choose the one that lets them, like, if you take that to the extreme, right? If you had a drug and you said, like, this is going to take 6 months off your life, but it's going to make the next 2 years so much better for you, I honestly think many patients would accept that kind of trade-off.
I agree. I think we're and then and just the hyper. I think I'm not saying we shouldn't get rid of mortality as far as an endpoint, because again, you don't want a toxic medication that's
Yeah.
killing people.
Yeah.
Right. But there's this focus on, oh, it was a negative study. But if you look at the study, you look at, okay, less people had renal failure. They didn't get out. Maybe they got out of the ICU faster, or they didn't get out of the ICU faster, but they have less renal failure. They have less intubation. Yep, mortality is the same. It didn't affect mortality compared to placebo, but the people that got the treatment had less morbidity. To me, that's amazing, right?
Yeah. Yeah, totally. I'm with you.
Yeah. So
One of the,
I think we have to. I just think we have to refocus. And I mean, are there patients who are there patients who help design these trials? Do you think that would be beneficial? I didn't mean to cut you off. Sorry, Dr. Matson.
No, by all means. And that's a really good question. So it depends on how the study's being done and designed and who's doing it. There's a huge push right now in patient-centered clinical trial design. If you're somebody like me who's a clinician investigator and you're trying to apply for federal funds and you say, we want to do a grant, we want a grant to be able to run a clinical trial, it is basically the expectation of certainly of PCORI, a patient-centered research funding organization, but also essentially an expectation of the NIH as well, that you have and have received and will continue to receive patient input as sort of a panel in how you're designing your outcomes and in monitoring and in how you report the findings. And certainly, like, I think that's incredibly important. And I think it's really well aligned for clinician investigators. And that's where I think, honestly, that's where I think we as the Academy, like 60 years ago, we were designing clinical trials. Over the last 60 years, industry, because of the money and the cost and how much money it takes to run one of these trials, like, you have to be very creative if you're a clinician scientist, if you want to get money to do a trial, because that's the other thing that is at play here in terms of incentives is, like, if I want to write a grant to, like, fund I have an R01 to fund our research lab, and that is, we're able to fund our lab for like 500,000 or something per year, which allows us to do the kind of papers that are, these biomarker-y papers, right? But in order to do a clinical trial, it's like a log scale or more money to do that, right? And like, there's not that much money, right? Especially if we're talking about, like, if I want to do interstitial lung disease trials, the NIH has funded like 2 of those ever, right? And so, like, now you're talking about, like, okay, we need here's somebody who's asking for 10 or 12 or 15 million dollars to do a trial from the NIH, where their budget is small-ish compared. I mean, they have to fund all these different studies across all these different platforms. And meanwhile, an industry trial, so like in the last year, in May of 2023, pharmaceutical company ran 2 trials in IPF and progressive pulmonary fibrosis. They were called the Fibraneer trials, and they were published in the New England Journal of Medicine. I think that those were $100 million-ish each to run that trial. It's 50 centers or more across multiple countries. They're paying for every patient outcome. And so if you're an academic medical center and you're used to getting that kind of money for industry trials, and then here comes a clinician investigator who's got paltry, Peaslee amount of money and saying, like, I want to do a trial, they're like, well, we usually get thousands of dollars for these studies. And I'm saying, like, you don't need it. Like, that's not how much it costs to do these studies. And so if there were ways and mechanisms, even potentially federally mandated, to say, like, we should set aside a big pot of money, more than we're giving to the NIH now. We should set aside a big pot of money to do this sort of what I consider like medical ground shots. Like, the NIH should fund moon shots, but at the same time, like, we should fund a way for the academy to take these drugs that pharmaceutical companies make and compare them to placebo. We should be able to take those into the real clinical space and say, how do they fit into our current treatment landscape? Multiple myeloma, for instance, has 11 therapies that are technically kind of within the first line, because there is no mechanism there for investigators to study head-to-head sequencing and to understand what's better for patients and, what patient factors and features might actually predict response to this kind of treatment versus this other kind of treatment.
Yeah.
And I think that, like, if there was a way to break that down, I think it would matter. And I think, to your point, like, mortality would probably, in many of those cases, not be the most important thing to look at. And, I think about this in our space. I think about that Everdac trial of arterial lines. And that was sort of one of the things that I've been thinking about too, which is a study that used mortality as a primary endpoint.
That
And
doesn't make sense.
it doesn't make sense. I mean, I don't know a single person who was putting an A-line in because they thought they were about to meaningfully impact patient survival. I mean, is that your impression?
No, that is not why I put it on arterial line.
Yeah.
That is precisely not. It's just, if it can help me, if it can help me take care of the patient better to get them better, and that's great. But if I'm looking at, is it as accurate as a non-invasive cuff? That's what the question should be. Is an arterial line as good as a cuff? And if the answer is yes, that's great. I save the patient a stick. I mean, when I was a fellow, I had the respiratory therapist do an ABG on me just to see how it felt. It hurt. It hurt for an hour. It hurt for an hour afterwards. So imagine having that line in, which is a nidus for infection and all these things. So I agree with you. I'm so happy to hear that, and I think you make very, very good points. I wanted to get your take. It was a week before last. I had Dr. Rafael Olive Leite. He's an intensivist out of Brazil, who is questioning the whole. I loved what he said, the whole sepsis epistemology. Like, he doesn't even think sepsis is a thing. And after reflecting on him, I think sepsis is a thing. I mean, my eldest daughter, she had cancer, had chemotherapy, and passed away from septic shock. So we see it. Sepsis, I think, is a thing. His point is, it's not a disease. It's that you can point. It's like and it's a syndrome. And that's why he's saying all this research is just for nothing. He just thinks it's not. Sepsis isn't an entity. It's just a phenotype of really bad infection. And so he just rails against the guidelines and rails against all the research that's being. He's trying to move the needle philosophically. I wanted to get someone from the academy. I was in Chicago at the SCCM when the guidelines came out, and a lot of, like, even the strong recommendations, I went over them on the podcast. There's nothing was like earth shattering, like just give antibiotics quickly and fluids. And so what's your take on that?
Yeah, that's a really great point. And something I always think about in any form of research is, the outputs can really only fundamentally be as good as the inputs. And one of the quotes that I always bring up whenever I talk about, in my space, interstitial lung disease, but I think it applies to sepsis equally, is yesterday's solutions have become today's problems. And one of the things that I think that he does a great job of pointing out, as you sort of have said, is the epistemology of how did we go from what was an incredibly important clinical observation, which is that, like, there are people that get infected that just get a lot sicker, and they have this process that affects all these other different organ systems. And, like, to go from the 80s, where that was sort of not organized, to early goal-directed therapy and sort of saying like sepsis is a thing that kills a lot of people and we should be aware of it, and that there are ways for us as a system to think about it and improve the care, like that shift was like monumental. But then I think his point is, then we have, on top of that now, we start to layer this entire research and regulatory infrastructure on top of the observation that sepsis is a thing that really matters. We should have these sort of like, we should build research programs around it to understand it. And we should start to have regulatory financial capturing of systems because there are endpoints for sepsis management that matter. And I think one of the difficulties is if you never go back and redefine it in a meaningful way based on sort of underlying biology or clinical behavior, instead what you have is sort of like the journalism of guidelines and regulatory stuff start to occur, such that like people build programs, research programs and guidelines all based on a assumption that like it's this thing. And I think his point is like, we don't even know what it is. We don't even know what that is, what's actually occurring. And in ILD, I think it's similar. Like I always talk about this in our space is like, there are 200 different etiologies that can lead to interstitial lung disease and pulmonary fibrosis. There's sort of like 3 big clinical buckets that we put people into that have important implications for treatment. But all of that entire system is based on like H&E slides from 1950, where 10 people were sitting around looking at slides together and saying, oh, these people look the same. We're going to call that usual interstitial pneumonia. And something's different about these people. We're going to call that non-specific interstitial pneumonia. And then we're going to build like 50 years of research on top of those, pattern recognition of 10 people looking at H&E slides. And what I always say, and I think it's true for sepsis, just like it's true for our condition, and it's true for probably many things across the academy, is it's a hypothetical built on top of a Jenga tower. And like, you have to kind of go further and further back to the beginning and try to actually understand what it is that whole thing is being built on, because so many assumptions are baked into all of this. And I think it's a real problem for all of it, all of us.
Yeah. No, that's a very good point. And I mean, but you make a very, very salient comment about the fact that in the past we just whatever about sepsis, and it kills a lot of people. It does, and I think maybe I think there's benefit in now making it a medical emergency. I agree with you whether we should have regulatory punishment if we don't follow out, metrics, process, and metrics that maybe it may not affect outcome or may even subject patients to unnecessary treatment. That's a whole other question.
Yeah.
And I think the thinking has changed and make us. And when I teach about sepsis, the first thing I say is we have to have a high index of suspicion because it's a very difficult disease to detect. Because there's no one test and they said that in the guidelines. It's not you can't have one test to do it. It's a syndrome. It's not so people come in differently and they manifest with sepsis differently. I'd love to have him and maybe you or other people on that together to kind of debate it. That would be a lot of fun for me. So, this, I think, I tell you, a lot of times in the community, we're like, the people in the academy sometimes have no idea what's going on in what we call the real world, right? And a lot of times these things come out, you're like, okay, what is this supposed to mean? And you're like, whatever. And I do really appreciate you, the fact that you really you still remember that you're there for the patient and that you're a clinician and a scientist, and that we need you in the academy, not only to teach us, right? We need teachers. I had Dr. Balk in Chicago. He was my teacher. I'm forever indebted to him. Dr. Dellinger was my teacher when he was in Chicago. I'm forever indebted to him. So we are indebted to you. You are the ones that train us and that make us the clinicians that go out in the community and try to take care of patients. And I love that you're continuing to to remember why you're doing the research in the first place is to help help your career. And I'm don't begrudge that. I want you to have a very successful career, and I love that you always remember the patient as well. So thank you, Dr. Matson, for all that you do. Thank you for your work, and it was an absolute pleasure to have you on the show.
Thanks so much for having me. This has been a great discussion, and yeah, I really appreciate it.
Thank you. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.